You may already be aware that opioid use is not just a crisis, it is an epidemic. And for that, there are different treatment options for people who have been caught in that struggle. In today's episodes, we will be talking about that and some of the options and opportunities that are available for people who are struggling with opioid use disorder. Welcome to Mindfulness Voyage. My name is Ted Meissner, and if you get something out of this episode, please do like and subscribe. It will help other people find it as well. So with that, let's talk with our guest today. Our guest today is Zev Schuman-Olivier. Zev, good to see you again. Thank you so much for your time today.
My pleasure. Glad to be here. Nice to see you again.
So we have a lot to unpack with this latest research, but for those who might not be familiar with you and your work, I'm wondering if you could just say a little bit about who you are and what it is that you do.
Well, um, I am an addiction psychiatrist by training, board certified addiction psychiatrist, and I am the director for the Center for Mindfulness and Compassion in the Department of Psychiatry at Cambridge Health Alliance and Harvard Medical School, where I'm an associate professor. I am both a clinician and a researcher, and I've been conducting research on mindfulness in healthcare and mental health for actually about 21 years now. Um, so I think that's me in brief, or my work at least in brief.
That covers it pretty well. Thank you for that. And why we're talking today is a particular study, and there are several different layers to it. I was rereading it this morning. Opioid use, craving, anxiety, and during a particular kind of treatment modality for opioid use disorder. I'm wondering if you could say just a little bit about what this research was about and how it got started.
How it got started, that's a whole different question. So it got started, I think if I look back, it was when I was on a Vipassana meditation retreat. And at the end of the retreat, I was sitting underneath a tree next to this man who was from New York City, who had grown up during the crack epidemic, and he was talking about how this meditation was his NA or AA, and this was back in 2000, and that made me think this is really important. Uh, and mindfulness, I had felt like mindfulness had helped me with behavior change in general, and I'd seen in others who were practicing how it shifted and changed behaviors. So I was very interested in mindfulness and behavior change. And so I got very interested in mindfulness and addictions um, after that conversation. Uh, um, and during medical school, um, I was um, I took an addictions medicine rotation, and it was 2004, and it was the first 3 months that buprenorphine was on the market and was able to be used, and it was the first place in the country that was really using it in a clinical way, not in a research trial. And what was amazing was all during medical school, we had the experience of people with opiate use disorder not being welcome, not being able to engage and care. It's very antagonistic. It hurt my heart. I think as a compassionate clinician, and I had a lot of empathy for what people were going through. And we had a group at the place where we were, and it was the first time that people with opiate use disorder ever attended a group. People would be relapsing, or they'd leave the hospital early. And so I started co-leading this group back in 2004 with the attending physician. And it was just a time for people to come together. And we got up to 20, 30 people in that group, everyone talking about how their lives are being changed by this medicine, buprenorphine. And it really has been a revolutionary medicine. It's become by now a first-line treatment for opiate use disorder. As opiate use disorder has also exploded in our country, and the opiate overdose epidemic has become an epidemic, from a crisis to an epidemic. And so it is the first line treatment now. But I saw early on that there were impacts from the groups that go beyond the impact just of the medication itself. In studies, if you just give the medication, about 50% of people will still be in treatment at 6 months. Now, keep in mind, that's compared to 3 to 5% without the medication. So it's a huge impact that this medication has. It's really impactful. But we can see up to 75, 80% completion rates with groups. And so I've just been very interested in that throughout my career, as I've been interested as well in mindfulness and understanding how mindfulness impacts behavior change. So I've been pursuing both of those in parallel. We've actually been studying at our Center for Mindfulness and Compassion the neural mechanisms of behavior change through the NIH Science of Behavior Change initiative. And we've, I think, published probably about 10 papers looking at things like the effects of body awareness and interoceptive awareness on behavior change and its role mediating the effects of mindfulness on behavior change. There's a paper called The Change Starts with the Body that you can look up. We've also been doing neuroimaging studies, understanding the effects on interoceptive awareness or internal body awareness, as well as emotion regulation and pain avoidance, pain anticipation, and the brain signatures that are linked to emotional resilience or the ability to maintain goal-directed behaviors despite emotional challenge. And all those suggest that mindfulness does have an impact on helping people initiate behavior change. So after those trials in primary care patients with anxiety, depression, and stress, we wanted to be able to apply what we had learned and what we had developed in our mindful behavior change program, which is an 8-week program similar to other 8-week mindfulness-based programs like MBSR, mindfulness-based stress reduction, or MBCT, mindfulness-based cognitive therapy. Also bringing in warm mindfulness approaches that are more explicit about self-compassion, inner compassion, warmth, inner warmth, and so we, which we felt was really important for behavior change, because so often what happens is when you set out to make a behavior early on, you fail. And it's really important to be explicit about how you should relate to yourself when you're having difficulty, when you're suffering, or when you fall short of your own goals. And so having that be explicit before you start making behavior change is really important. So we've added those kinds of threads to this program, as well as basically integrating all the best practices and around mindfulness-based interventions for behavior change, and integrating it also with some of the historical Buddhist psychology around what helps people change behavior. So that's the 8-week mindful behavior change program, which we call it's a warm mindfulness-based program. So it's MBP. We have a teacher training program, a group leader training program that has expanded. I think we've trained probably 120 different group leaders so far, and so we implemented that across our entire healthcare system, and at the level of primary care. And we wanted to see if we could expand this and extend it to this group-based opiate treatment. So kind of separately, I've been doing research for a decade on buprenorphine treatment, and one of the things that we've been looking at is what are the impacts of groups. And there's never really been a large randomized controlled trial of group-based opiate treatment. And so we were able to get a pilot study funded by NIH through the HEAL initiative, um, it's called the BRIM initiative, which was basically to support behavioral interventions during medication treatment. So it was a perfect fit when it arrived, and so we were able to do that. And in our first pilot study, we found that people liked it. We had 72% completion rates, retention rates at 6 months, and we found that people reduced anxiety with a large effect. We also saw reductions in pain interference, in fact, the impact of chronic pain in their lives. We saw reductions in benzodiazepine use, as well as for anxiety, as well as reductions in cocaine use, which is frequently something that people are dabbling with in opioid treatment. And then we built on that, and we proposed a 5-site randomized controlled trial in primary care across Massachusetts. And we got funded for that. So we took about 9 months and built that trial. And, it's a long process to be able to get these projects approved. And on was it March 14th, 2020, we got approved to start. And that was the day that COVID ended up leading to Massachusetts closing. So the story of this trial is really a story of being like water, and the way it goes around rocks is there's been so many rocks, and you keep flowing in the direction, and eventually you find a way to be able to do it. So we were able to have this study get changed to be an online study, and we decided to run this, which would be the first remotely conducted study with a national sample. And so we learned how to do national recruitment on Facebook. We are Meta now, and other types of social media. We sent out 3,000 letters to every provider of buprenorphine in 16 different states. And we started to collaborate with online telemedicine buprenorphine delivery companies like Bicycle Health and Boulder Care. And doing all that together really helped us to be able to help find people that would be interested in a stress reduction study during opioid use disorder. We screened out people who didn't have anxiety, or we wanted people that had some level of instability and needed some kind of support. So either they were on buprenorphine and still had clinical levels of anxiety, or they had relapsed in the last 30 days, or they reported that they had used recently. And so based on that, we were able to enroll and screen 260 people, and then randomize 196 adults, again, across 16 states. And we were intentional in trying to get states in all 4 main geographic regions of the United States. So this would be a geographically diverse sample. I think there can be critiques about mindfulness being a thing for East Coast and West Coast folks, and not for the rest of the country. And so we wanted to make sure that we engaged people across the country. And people got randomized to either get a mindfulness training group, which we called Mindful Recovery Opioid Care Continuum, or MROC. And we compared that with what was called our group-based opiate treatment or recovery support group as a control. And one of the things that happened in switching the study when building it is we had to figure out, how do you do the things that you normally do in these kind of studies, like toxicology testing, which is usually done by giving out, urine tests. Um, and and so we invested in oral fluid testing technology. We sent people kits to their house, and we watched them on video while they would do their swabs before the group, to have it kind of feel like people would show up into like a waiting room area where they could mingle with each other and talk, and it was just social. But then we pull people out for 3 or 4 minutes. We check in with them briefly and do their toxicology screen, and then they go back to the group. And then after that, they go into the groups for an hour at a time. And we ran the groups at the same time, so that way, and the same day, so that way we would be able to manage that. So it took like six people a day for every time we were running groups to be able to manage all of that. So it was quite a feat, and I'm really grateful for all the commitment from everybody on the study team. We really could have done it without nearly a 20-person team over the course of time. So the groups we were comparing, the mindfulness group was a 24-week group, and actually both groups are 24 weeks. The recovery support group was specifically chosen, and we were funded because of it, because NIH was interested in somebody that'd be willing to put a strong active control group with evidence-based treatments up against mindfulness. And we were willing to do that. And so we used the best practices group-based opiate treatment manual that we had developed and been using clinically, that integrated 4 different evidence-based programs for substance use disorder. So it was based on 12-step facilitation, motivational interviewing, CBT, cognitive behavioral therapy, and motivational interviewing concepts. And it was all within this context of the best practice group therapy, of creating connection, creating empathy with each other, creating accountability. So that was kind of the focus of those groups. And we actually were lucky because the very first, again, remember this is COVID, so there are people who were doing online groups, but the very first intensive outpatient program to open in Massachusetts was led by a really skilled clinician, who was also very technically skilled and charismatic. And so we were able to get him to be the control arm clinician. So we felt really confident in the control arm. And then in the mindfulness arm, we were able to train nurses, social workers, psychologists, and primary care MDs to be able to get trained in our mindful behavior change program. And then we did an additional workshop training to train them to apply mindfulness to addiction. And they co-led groups throughout the study. And there was a lot of, I would say actually the first 3 groups were quite a challenge, just in both arms. It was the Delta and then the Omicron waves, and during those times, we had dropout of both groups. There was just people would drop out saying, someone in my family died, my father died, my mother died, my spouse died, and it was just happening a lot. But once we started our 4th group and kind of got through the Omicron, just like the rest of the country, then we saw more regular retention rates. Anyway, that's just to say that the retention rate overall in the study was a little bit lower than we expected. And part of that had to do with kind of the time that we were living through and running the study through.
Yeah, and you're not alone in that. There's so many studies that I'm seeing that are coming out now that were done during major changes of COVID.
Right.
So it comes up, and post about these, and there are always some raised eyebrows about, but that was a couple of years ago. I'm like, well, yeah, because it takes a while to get through these as you're describing.
I also want to highlight that, it wasn't just COVID, it was also, what happened after George Floyd was killed and the protests and the tension around that. So it was interesting as we were doing a study nationally with people from multiple different states. We had people joining from rural Alabama, we had people from New York City. We were bringing people together, and that generally worked pretty well. Actually, there was, I think, one group where somebody had a something that was potentially offensive, or to other folks on their wall behind them, and that the group had to work through that. Um, but that was some important learning for us about both the opportunities and the challenges of doing uh, diverse geographic study.
Yeah, online stuff and this,
Yeah.
having taught programs on how to do mindfulness live online, is you have an unprecedented view, in literal view, into people's personal lives.
Yeah.
And that is also something to manage as part of the structure, particularly around research like this and in groups that are very mixed. And and you also mentioned you worked through that as a group too. That is also one of the opportunities that's afforded by that.
Yes, I think so. Um, so the study overall, we analyzed the data. We found that there was not a difference. But we looked at the last 12 weeks of the 24-week time period, and we looked at whether or not people had positive oral fluid testing for opioids, as well as whether or not they reported any kind of opioid use. And if either one of those were positive, then they were counted as positive for having had a opiate use non-abstinence during that time period. And we had 6 time periods in the last 12 weeks. And so we looked at everybody's 6 time periods. And interestingly, what we found was that there was no difference between groups. It was almost exactly the same between the two groups. And I don't know, can I show? Do you want me to show figures from the tables?
Yeah, let
Or should we
me
just link to it and people can find it if they want to?
let's link to it because I will have a link to the study, and so people will be able to see that there. Well, we can handle it that way, but
Okay.
that will link to the study so people will be able to see it.
Okay, yeah. So basically it was around 13% of people on average had um, who had opioid use per during the per time period for the study, and it was about the same for both groups. And what that says to me is um, that we didn't find superiority between either arm, whether it's the evidence-based best practices group with all the kind of traditional substance use programs, or a fully mindfulness arm, which doesn't have any of that stuff in it.
Which is
And
interesting because I keep running across the phrase non-inferior. So there are programs that are treatment as usual, for example, and
Mhm.
then mindfulness, which does not have that kind of intervention in it, and it's ballpark in the same territory.
Yeah. So what we can say is there are specific studies that test for non-inferiority. We did not set up the study and power it to test for non-inferiority. We probably would have needed, instead of 196 people, we probably would have needed like 400 or 500 people to
Yeah.
definitively say that there's no difference between groups and it's non-inferior. That being said, if you ran the non-inferiority statistics on this, it would show that it was non-inferior. But it wasn't powered to be a non-inferiority study. So there's that caveat there.
Yep.
Um, and so in that way, one might say that there's a negative outcome, but what I think what it is showing is that neither is superior to the other. And what that means to me is that if you are on buprenorphine and you're having anxiety, or you're having risk of relapse, and you want to do mindfulness as your treatment program, um, uh, and then that should be legitimate and that should be supported, and that's a viable option for opiate use disorder and treatment and substance use treatment. Um, uh, at the same time, I would say that the other standard treatments are also effective, and group in general is strong and supportive and effective. So I think what's nice is it gives people options, and I think people deserve those options. And if you're doing that in the group, that should be something that is supported, by healthcare payers, and by healthcare systems. And the next step is really figuring out how to help implement this kind of opportunity. And the fact that we can do it online and it doesn't be in person means that you also could get to economies of scale where you're offering these kinds of groups and from various different health systems that could then participate. I think one of the things uh, um, that's important to think about, though, I guess to put just a little bit more specification to what I'm saying, is that we had a trauma-informed mindfulness program, and we specifically designed that in several ways. First, we followed important trauma-informed principles of mindfulness, so people always have choice. We assume that everybody in the room had trauma. It might not be true that everybody did, but we assume that so that we never, and so that we could teach everybody about the importance of working with the symptoms that relate to trauma. And one of the things we talked a lot about in the very first sessions are the window of tolerance, and help people to find that window within which they can stop experientially avoiding unpleasant experience, but also letting them know that if they get to the point where it's hard to be with, that they can be skillful in choosing how to care for themselves. And that might be through self-compassion, it might be through some other type of grounding strategy, but we were explicit about that.
And that's such an important aspect to programs in general. Is it doesn't have to be a background of significant trauma. It can be difficulties, and helping participants understand that choice point of, is this something where there's growing here and I'm challenged, but I'm okay? Or do I actually need to, rather than engage with it, is it appropriate for me to pause,
Right.
to take a little bit of a retreat to encourage, re-energize, and stabilize myself before going back into working with difficulties?
Yes, exactly. You gave a great point about the word choice point. We actually wrote a paper about that from our primary care studies, because we were able to have a patient who had a dissociative identity disorder, or dissociative, not dissociative identity disorder, dissociative and depersonalization disorder. Um, and and they had a lot of dissociative symptoms, and came into the group hoping to work on that. And one of the things that we did with them was give them a lot of different choice points, and they were able to really find it helpful and have a reduction in symptoms. So um, uh, I should say, parenthetically, from that study, what we found was that people with PTSD diagnoses were actually the most likely in our warm mindfulness trauma informed intervention to be the ones that initiated behavior change. They had the highest rates of behavior change initiation, which is interesting. I actually think in the mindfulness field, it is folks that have not recognized their trauma or talked about it where the biggest risk is. I like to think of that as the anxiety NOS, or anxiety not otherwise specified group from a mental health standpoint. People who are anxious and aren't sure why, but when they sit down, they suddenly remember, what they didn't want to remember. I think that's the biggest area of concern. And that's an area of concern that we had for this study in particular. So we really want to prepare people for what to do and how to work with that.
Yeah, it is. It's such an important aspect to this that you bring up, Zev, is this idea of maybe fully aware of traumatic events in my life, and There's that framework of a past that can't be changed, but the choices I make and how to deal with it. And when there's not an understanding of events, that may mean that there has been a very strong practice of avoidance or suppression that itself can be one of the challenges to be worked with and overcome.
I think that's the biggest risk in mindfulness. For us to be aware of, and we really try to. One of the things we do is we give people lots of different places to pay attention. So you generally start all of our practices with paying attention to sounds, and then paying attention to feet on the floor and points of contact between the self and body in the chair, and then going to breath, for instance. So all of those can be anchors, and you can kind of go back through all the different layers and pick which one feels the one where you can find safety or anchor again, and then restart the practice. But when I was training, it was specifically focused on breath was what you used, and
AOB, awareness of breath, and that's it.
and I learned probably almost 20 years ago, or no, 15 years ago now, that wasn't what was the best anchor for everyone. So we really try to give a lot of choice in that way.
Yeah,
Um,
yeah.
so what we did find was that both groups had very large reductions in anxiety, almost 10-point reductions in anxiety on a T score scale, standardized score, which is enough, to go from mild to moderate anxiety to minimal or no anxiety, and that speaks to the value, I think, of the group impact, as well as the skills that they learned, whether it be CBT skills or mindfulness skills. But it was exactly the same, the curves, to watch the reduction, that was a surprise. I thought mindfulness would outperform the evidence-based programs.
I was going
Um,
to ask you about surprises with this. That's one of
um,
them, and yeah,
in
keep talking
retrospect,
about that or some other things
well,
that surprised you
in
with it.
retrospect, neither is surprising, because what we know from meta-analyses is that in substance use disorder is that mindfulness is better than wait list or passive controls, um, and maybe a little better than active but not evidence-based controls, but not no different than evidence-based controls for substance use disorder. And if you look at anxiety, the same thing is true. Mindfulness is about, I'm not going to say non-inferior, but is about as good as other types of treatment, evidence-based treatments. But they're all better than passive or controls. And so I guess I should have expected that would be. We had one other outcome which was particularly interesting, and that was the opioid craving outcome. And we tested craving every week, and we asked people on a three item 10-point scale about how much craving they had, if they imagined using right now, how much would they want to use? What's the likelihood if they're in the same situation where they used before that they would? And so we asked them that regularly, and you can see in the paper there's a really, I think, good demonstration of how over time mindfulness reduced craving significantly more than the control group. So 67% reduction in craving in the mindfulness group compared to about a 40% reduction in the control group. And that was statistically significant both by week 3 and then again by week 11, all the way out to the end of the study. And in fact, what we found is that the more that the more groups they attended of the mindfulness groups, the more likely they were to have reductions in craving. We've been trying to understand what might be some of the mechanisms, or what might it be about the mindfulness group that did that, and we're still looking into that. But what's interesting is that we started, the one thing I didn't mention is part of our being trauma informed and motivationally sensitive was that we didn't want to force people into mindfulness or intensive mindfulness. I think that's important. We can do harm. It can be iatrogenic. I'm really, I love when we give, like population health, when we give people the opportunities to practice mindfulness, but I cringe when mindfulness is brought into systems, for instance, like schools in certain ways. It can be done really well in schools. It can be also be done in ways that backfires, where where kids go in, and it's like, oh, there's the teacher, they're forcing us to do this again. I think being forced to do mindfulness is always wrong in my mind. And so, but I think it's a great option. And when there's that approach mindset to it, and people are curious and open and want to see what it's going to be like for them, they're more likely to have a good impact and less likely to have adverse effects. So we gave them 8 weeks. The first 4 weeks were really focused on some key concepts of, increasing their curiosity, helping them make commitment, helping them to connect with the group, and helping them to feel safe in the group, have comfort in the group. So that's like kind of the first 4 sessions are based on that, and they just introduce mindfulness practices, just to get that the taste of what it is they're doing. But there wasn't an expectation to practice, more than 5 minutes a week, and so that's 5 minutes a day. So that's important because one of the things that we learned is that by using an ascending practice dose ladder, which we had tested in previous studies, where you increase by 5 minutes per day every week, instead of jumping right into like a 30-minute or 40-minute practice, you're less likely that people drop out. What my experience was when we had people and we started at 30 minutes a day in the first session, a lot of folks just dropped out and felt bad about themselves, but they couldn't do it. And I think it was not trauma informed, and it was not motivationally sensitive, and it led to more self-stigma they might have felt. And so we, over those first 8 weeks, we build up basically with the idea to 20 to 40 minutes a day of practice. And anyone who got to 20 minutes a day of practice was strongly encouraged to continue. And so what we did see is early on, actually, there was this difference in craving by week 3 of the study. And then we start introducing these kinds of a few different practices, but primarily for the idea of grounding. So the idea was these were trauma-informed practices, so that people would feel like they had practices that would be safe if they needed to. And then starting week 9, we went into the mindful behavior change intensive after we warned people that they were going to do that. And once we do that, we see then we're doing a more standard mindfulness-based program curriculum. Again, it's based on the mindful behavior change program, with hour-long sessions over 16 weeks. And we start to see the massive change in craving once that starts. We started with the body scan, and we have a specific practice about mapping out your autopilot reactions, not just with substances, but with your phone, but with eating, with relationships. And so everyone gets to put up all the different autopilots they have, including the group leader. And so we all become able to destigmatize the idea of autopilot and automatic behaviors. And then from there, be able to start paying attention to them and working with all of them. Yeah.
Zev, I'm wondering if I can ask a question about what you mentioned about the results on craving, that there was this self-reported, so that is a factor to this, that is self-reported. So it's a perception, a reduction in craving, and fairly early on at the 3-week mark. And what I find very interesting is that this is a different result in a different study in different context. So bearing that in mind, that I just posted about this morning on LinkedIn, that what may often happen is that around week 2 or 3 of say an 8-week standard program, which again, very different structure. It starts with 45 minutes of practice. Those are heavyweight. that in those first few weeks, there's an increase in awareness, an increase in sensitivity that can feel like things are getting worse. I'm more distressed. I'm feeling more, whatever it happens to be, rather than less. And that it takes a little while to then begin to work with whatever it is that's coming up. I'm wondering about your thoughts with
Well,
that, why
if
that
you
would
look
be
at
a
the
different
opioid
thing in
craving
them.
graph by week, 5, it starts to, um, the groups are similar again. So the difference is lost, and that persists until, until you're into week 10, basically, until you're into the intensive program. So it might be that, um, that actually we should have started the intensive, 4 weeks earlier, um, uh, to just, move through that, with deeper skills. But yeah, they may have like stalled out a little bit in that, in some ways we were teaching them more grounding skills to be able to prepare them in a trauma informed way, and maybe people would have been ready for it earlier. It's one of the questions that we're asking. But you're right. Usually around weeks 3 or 4 of an MBI, people are starting to turn towards the unpleasant, notice the unpleasant, and it can be harder for a few sessions as people are starting to like be with what was there. But ultimately, the vast majority will move through that successfully, and it is important to be able to be with both the pleasant and the unpleasant and the neutral. So speaking of that, one of the things that was unique about this study was that we also started in week 9 teaching the informal mindfulness practice called Stop, Ache, and Go. And I'll tell you about that. The idea was to develop a trauma-informed approach that actually integrated both mindfulness and compassion into an informal practice that you could do to work with craving, that you could do to work with um, to work with other emotions, because we know that not just craving, but negative affect can lead to craving and substance use. Um, Stress can lead to craving and substance use. So we wanted one practice that people could do, and so it builds up over the course of those 16 weeks until people feel really able to do all the different cognitive and emotional and self-related shifts that I think you see in those that have taken a mindfulness-based approach to the highest level. And we wanted to think about how can we actually make these available and teach people how to be skillful in navigating being with things. It's not just one way to be with any moment. And so sometimes in the mindfulness-based interventions, there's like one thing. There's, you just always go back to the same thing. This is what you're going to do: a 3-minute breathing space, or, for example, which I think is really helpful. And there might be ways to make it even more impactful. So things like 3-minute breathing space, urge surfing, and mindfulness-based relapse prevention. There's there's the RAIN acronym that people sometimes use. All of these are helpful concepts, but our feeling was how can we use the best? As I said, use the best of what's out there, and see if we create something that's even more trauma informed and that integrates a warm mindfulness approach. So stop. It's what's nice about this is as you move through the letters, you can decide if what's right for you in this moment. So you can either stop or you can just slow down. If you really can't stop whatever's going on, just try to slow it down a little bit. And then T, turn towards experience. So again, having this approach orientation, turning towards. But if you can't, just take notice of your breath or your feet or the sounds in the room or the contact between the body and the chair. Observe. So in this case, we taught about the diamond of experience, which if you think about like a diamond like this, you have thoughts, body sensations, emotions, urges or behaviors. And in the middle is feeling tone: pleasant, unpleasant, neutral. Just observe. What happens is whenever we have an emotion or we have a thought or we witness something, we start to go around, and it creates this like avalanche of thoughts, feelings, behaviors, urges, emotions. And the feeling tone usually is pleasant or unpleasant. But if you can just become fully aware and not react to anything in that diamond of experience, it'll start to slow down. Um, and so we have people just observe and notice what's in their experience to kind of make their diamond of experience in that moment. Um, and then P is, if you didn't notice whether this was pleasant, unpleasant, or neutral, go to the pleasantness. Notice how pleasant this is or how unpleasant it is. With the idea that Vedana, this comes from Buddhist psychology, obviously, but that Vedana, or the feeling tone, affective valence is in some ways one of the potentially most efficient places to be able to notice and break this cycle. Um, and then from there, so you've stopped, and now there's some ache here. And so what's the ache? We want to allow whatever's there to be there. And if you can't allow it, then and accept that this is the ache, can you at least like try to find an anchor then somewhere? So an anchor again in the breath, in the feet, in the sounds in the room, in the touch, in the feelings with the chair. We don't need to accept something. Acceptance doesn't mean we are approving of something, which just means we're allowing it, that the reality that it's here is here. And then we move into C, which is essentially paying attention to the body and seeing where there is suffering, if suffering is here, and turning towards it with compassion. And if there's not suffering there, and in fact what there is craving there, can we pay attention to that with curiosity? Like sometimes there's just wanting. There's just wanting. And can we just be curious about that? Because curiosity has a way of getting us out of being caught in the automatic wanting. And then H, just trying to hold there. And again, by holding, and so by holding, we can start to unravel the cycles of experiential avoidance, where we want to avoid the unpleasant and we try to react. And just holding it for a few seconds, of whether it's holding in compassion, holding in allowing, holding in curiosity. And sometimes it's even hard to hold without actually holding yourself. So, one of my colleagues, Chris Germer and Kristen Neff, kind of developed these different ways of self-soothing and self-touch, whether it be holding your heart or touching your face or holding your arm. So some kind of soothing touch could be appropriate. So we teach people to think about that there.
And I want to mention something that you had brought up earlier, Vedana, the feeling tone. For those who are not familiar with that, here when we say feeling tone, we don't mean feeling as in emotion. We mean feeling as pleasant, unpleasant, or neither of those. So just a clarification if you're not familiar with that, if you haven't run into that before.
Yes, thank you. That was the Pali word for it. And then people go from wherever that kind of space of suffering was in the body, and expand from there throughout the body. And then the go part is to just take a moment to connect with gratitude that you took this time, you took this moment, that you have this practice, that everything changes, and then connect with grounding values. And we have this values card sort that we do in a mindful way, a mindful values card sort. It helps people to identify what are the core values in their life that they already have, right? We're not trying to change core values, but they have the core values, but maybe they're not being seen or they're getting overwhelmed by other values. But what are 3 core values that they already have, but that they'd like to really focus in on more, and that might align with them thriving in their life or the way they see their life going. And so basically it becomes like, I don't know if you ever rock climbed, but it's really tiring to rock climb just with your arms. You can't make it up very far. What you need is a foothold. You need to be able to put your foot on something, ground that foot, and from there you can move in the opposite direction or move in a direction. And so I see grounding values as that. So G is connect with your grounding values. You might be reminding yourself that mindfulness, compassion, and family or health are important to you. And from there, you can kind of then go, oh, you go out into the world with openness uh, and um, and kindness. And so then we train folks also with various different types of open awareness practices and kind awareness practices to be able to then reorient how you're going to see and be with what you're experiencing. So that's kind of the arc of the course, and every session is building on that stop, bake, and go, and then people are able to start to do that as an automatic process, and then have the skillfulness built in to know how to navigate. And that took me 20 years to learn, in going to meditation retreats and going to different programs to be able to understand that that's actually what you need to be able to go to the next level. And so that's that's the core of the mindful recovery opiate care continuum and the mindful behavior change program. We actually have a mindful behavior change group leader training this fall in November. We try to run it every year, every other year, depending on when we have studies and things like that. I think people love it. It's a great opportunity. It's online, so you can take it from anywhere. And sorry, I was looking off to the side a little bit. So, you can see that on our website, www.chacmc.org. You can also find our different research on topics related to mindful behavior change there.
Yeah, and for folks who are watching or listening to this, I have links in the description for this episode to the things that Zev is speaking about here. And I just wanted to ask one last question before I let you go, is for those who may be struggling with opioid use, either themselves or people who are close to them. What's just one thing you might share with them and what they're encountering?
So I think one of the things that I see happening is that people sometimes, especially family members, have hesitation about supporting loved ones to be in medication-based treatment, like buprenorphine. People say things that I think are based on historical ideas about how medications might work, and also the difficulties people have had managing medications. To think that it's like replacing one drug with another. But I want to say that buprenorphine is safe. It actually blocks opioid overdose. It has a sealing effect on the opioid receptor, so it actually prevents other opioids from working. And it's been widely disseminated for that reason as a safe and effective medication. And it really is. It's felt like a miracle medication where I've seen it. And what I want to say is, if you have concerns about that, that bringing something like mindfulness together with buprenorphine has the capacity to help people not just to be able to deal with the symptoms of withdrawal and show up, but now they can actually do that recovery work and get what I call therapeutic neuroplasticity. What happens when we start using drugs is that it actually changes the brain. Neuroplasticity, it's neuroplastic, it's changing the brain. And these circuits change the brain where our reward system doesn't notice anything except for the drug as important. Other things that are important, like family, might fall by the wayside. It becomes hard to weigh out consequences of your actions or think into the future. It can become hard to have empathy or care about others. And part of what, and it can be very depressing as well when you don't have the drug because nothing feels like it matters. So there's no motivation. And part of what we're seeing now is that mindfulness is helping to address several of those areas of neuroplasticity. And it has its own therapeutic neuroplasticity. It starts to change the brain and the wiring in the brain to be able to allow people to be able to this is Eric Garland's work, to be able to experience pleasant events again by savoring. So we do bring his mindful savoring program into our program as well. And then we do teach the urge surfing practice, which is essentially involved in helping people ride the wave of craving. So instead of if you've ever seen a hurricane, when the waves come in, if you try to stop them like those like a big concrete wall, then the water just shoots up, right? And so trying to stop craving just makes it worse. It just intensifies it. What we need to learn to do is how to let it move through us and then out of us. And it might come again in a wave again. But if we can learn how to surf it by using a practice like Stop, Bake, and Go as an urge surfing practice, then we can watch it come through. We can observe it, notice its pleasantness or unpleasantness, allow it to be there. Even stay with it and give ourselves what we need to get through it, and then expand and let it pass, and then reconnect with what our grounding values are, and open back up, and it'll feel different. So I guess what I'm trying to say is that I think there's a place for medication and meditation. I just call it the actual middle path here for addictions treatment and for mental health treatment. And so I don't think we should be cautious about the impacts of stigma and self-stigma on people's ability to actually get the care they need. And in this case, in this study, we see the potential for synergy between medication and group and community, which is also a really important piece of meditation. I guess that's the last thing, is that there are a lot of apps out there, and I can't speak to specific apps or, if any are trauma informed or not, but I do think that if you're hearing this and you're thinking, this sounds good to me, I'll just get that app and start practicing. That may be something that could work for you. But my recommendation would be more to find a mindfulness group with a group leader who has experience working with addiction or trauma in the past, so that you can really get the support that you need and get into stable recovery.
Yeah, completely agree. In fact, just yesterday, Zev, I released a couple of videos on different social media platforms about some of the awarenesses around app use, that downloading an app and picking a random meditation is the same thing as going to the pharmacy and taking a random pill off the shelf because you heard that medications are good for you. It's a very different thing than talking to your pharmacist, talking with your doctor, someone who actually has a background in this, and that connection of being with others on the same journey is such an important aspect of this progression of behavioral change. So thank you so much for bringing that up as well.
In studies, only about 10% of people, continue with an app after 7 days. But there are ways that it can be skillful means for folks, and group isn't like available to everybody. And so if you're wanting to be curious about it, then it's something to think about, but also to recognize that it's a different thing than what a program like this that's been designed through both years of best practices in mindfulness-based practices and trauma-informed care, delivered with skilled support and supervision, as well as integration with a process of iterations of scientific improvement to be focused on mindfulness and behavior change. So I do think there is that difference there. But yeah, what I'd say is that if you can't find a mindfulness group, then our study suggests that even finding some other type of group-based opiate treatment in your area could be impactful, for many people, that community keeps them clean back again and again.
Yeah, can make a very big difference. Well, Zev, thank you so much for your time today. Again, those who are watching or listening, I'm going to have links where you find links on these episodes. And Zev, thank you so much for your time today.
Thank you for the invitation, and I wish everybody well.
Thanks so much for tuning in today. And Zev, thank you and your team for all of your dedicated work on this really big issue that we're facing in today's world. For those of you who are watching and got something out of this, again, please do like and subscribe. You're welcome to share this with others too. And remember, every moment you have a choice. Make it the best you can. And I'll see you again soon on Mindfulness Voyage.